Hi, this is Elliot Fishman, and welcome to our latest podcast. And today is October 11th. Welcome, everybody. And the topic today is potential legal implications of AI in radiology. And not that I'm particularly worried about that, but I spoke at a meeting this week. Today's Thursday. I spoke at a meeting on Tuesday on this panel, and it was a great meeting. It was I'm reading my badge. Here's my badge. You see that? Very nice badge. But it's the ASHRM 2018, and that stands for the American Society for Healthcare Risk Management. And so what this meeting was a few thousand people who were the risk managers. I met Garrett from Hopkins, who's the chief legal person at Hopkins, was there. And many people from the big to the small hospitals were there. Risk management and risk minimization is obviously a very hot topic. It's something that's very important because we want patient safety, and whether you're a small hospital or a large hospital, there are many risks we all deal with, whether it's something that happens in radiology or anywhere else, a patient falling, whether it's misdiagnosis, whether it's the problems with foreign bodies not found. Whatever the issue is, the idea is how do you mitigate risk? And of course, we all know, I did walk around this meeting, there were a number of different vendors, and I looked at the program and listened to a few talks, and really it's how do you prevent bad things from happening? And I think risk management is not so much, oh my God, someone fell, someone missed something, someone got hurt. What do we do about it? It's more trying to figure out how do we prevent it. And I'm sure all of you in your hospitals look at that process as well. Remember, we used to have problems with patients falling in radiology. Patient would get up out of the wheelchair and fall down. And we figured out ways of making sure that doesn't happen. Patient falling off tables in the x-ray room. Seems like crazy, but it does happen. How do you make certain that bad things don't happen? Okay, so that's what the meeting was about. The panel I was in was this really good panel, 4 of us, moderator makes 5. And the question was to look for risk management people, what's going to be the impact of AI? Not that AI is here today, though it's getting there, it seems faster, but what does it really mean if AI comes along? What's the risks and what's the reward? So the simple thing is going to be, well, if AI doesn't work, if AI never becomes important, then there really is no issue, right? If AI just is one more of those crazy things that skyrockets up and skyrockets down, then there's no issue. But what if AI is really good, and that's what I spoke about, why I think AI is going to be really good. The question is, do you have to use it? So we all will miss things. So we're working on the Felix project, detecting early pancreatic cancer with AI. What if we're really good? We're going to be great at it. What if you don't use it? Let's say it becomes available, however it becomes available, we give it away, whatever. What do? Do you have to use it? And if you don't use it and someone misses a cancer, which invariably will happen, are you responsible that you should have used it? Can you be sued that you should have used it? So if the FDA makes software available for whether it's pancreas or liver or breast or fractures, what's your responsibility? Do you have to use it? And if you don't use it, are you going to be liable if you miss something? Okay, that's a very good question. Because then it becomes, when's the point where something is really good that everyone needs it? Remember CT, only a few places had CT, then everyone had CT. MR, only a few places had MR, then everybody had MR, okay? So what is that tipping point where you go from, well, it's an interesting tool that maybe those clowns at Hopkins are using, to where every 80-bed hospital has to use it? That's an interesting point, and for risk managers, it's very important to consider, when do you need to require something? It's the point, when does something go from being potentially helpful to being mandatory? So we discussed that. We also discussed, there's some practical things. Let's say I'm reading a case, and remember, I'm the expert reader. The way we think about it is, at least the first versions of software will be that the computer will suggest something, And then you look and you, the radiologist, will have the final say. Let's say the computer says there's something there, and you see it, and you missed it at first. Well, then you say, okay, there's something there. Terrific. Thank you, Mr. Computer. But let's say you look and you say there's nothing there, and the computer marks something down. You look again and you say, I don't see anything. The computer's wrong. And the computer undoubtedly will be wrong. As we program the computers, we're trying to minimize the false positives because false positives drive people crazy. But you always have this balance of false positives because you don't want to miss the smaller lesions. But on the other hand, there's going to be a point where the computer and you will disagree. What do you need to say? Do you need to say that, oh, I think there's nothing there? Normal. Do you need to say, I think there's nothing there, but the computer says there is, but I still think it's normal? Or do you need to report, well, you can believe me, you can believe the computer. Which one you want to believe? It's an interesting question because let's say, for example, you look at the computer says there's a lesion, you look and say, no, there's not, and it ends up there is a lesion present. Then what happens? Are you liable? So a lot of it's going to really be very dependent on how good the computers are. And the question will be is, can the computers detect pathology that's not obvious? We think at some point with texture mapping, with radiomics, that is going to be the case. And when it is the case, it's going to be a very, very complex problem. Now, I do know, I don't do mammo, obviously, but I do know that many people use the equivalent of an expert read on mammo where the computer suggests the presence of lesions. And then you can make a decision whether you want to listen to the computer or not. But I'm told, and many of you in the audience might have more experience than me, that whatever the computer says, that data is not kept. So really, it's a helper, but it's not firmly there. So nobody could go back after, and when you miss the lesion and say, hey, you missed this lesion, the computer told you it was a lesion, idiot. What the hell were you thinking? And I'm suing your ass off. By throwing away the data, that doesn't happen. Now, I do have a lot of uncomfortable feelings about the fact that you use a computer, but you don't say and keep the data it provided to you. I can understand where the state of the art might be the computer is helpful, but the computer is not the final word. It's the radiologist, and the liability does not sit there after you look at the computer's recommendations and you make your conclusion that the radiologist is the final say, and it's he or she that needs to make the final conclusion. I'm very comfortable with that, and the fact is, if we have the data from the computer, perhaps someday it's going to be helpful for us as a way of improving the computer algorithms, but also improving ourselves. So we can look back and do QA and see, well, the computer said something, maybe I should look more carefully. I think that's a major issue. I think that will need to be addressed in this entire AI paradigm. You also will look at AI in terms of practices as something that can be done to help you besides reading images. So obviously we're centered on reading images because that's what we do for a living. But there's many things AI can do, and that will be actually probably easier to implement than the clinical aspects. So AI now is being used to schedule appointments. AI now is being used to manage workflow. AI now is being used to manage supply chains. AI is being used to call the patients with results. AI is being used to remind the patient that their scan is tomorrow at 9 o'clock and not to forget about it. We're having a speaker from Amazon come. One of the really good, David Abitsky, who's the chief evangelist for Alexa and Echo, will be coming here this coming Wednesday, the 17th of October. You're free to join us if you're in the area. He'll be speaking about how voice and computers become very critical, how you can use voice perhaps as a way of helping the patient prep for studies or understand the studies. Hey Alexa, tell me about the CT I'm getting tomorrow. Can Alexa do that? Of course Alexa can do that, and probably people are working really hard at Amazon with their new healthcare system making that happen while the rest of us are sitting here talking to a TV monitor on Facebook. I'm just joking. But the truth is, I think that is really going to be, again, that whole process of AI. So when you think about AI, it's not just reading the films, it's everything we do. So I think with AI, the whole idea about voice, the whole idea about communications, the whole idea about knowing what you need to know and having a device like a Alexa give you the information becomes very, very important. The question is, how are you going to manage that? How are you going to integrate that? How are you going to develop and maintain that? Those are all really good questions, but I think it's not a question of will it happen. The only question is when. And so, for example, when we meet with David this week, we're going to speak about potentially what can we do in surgery, whether Alexa can control the images. So Alexa, show me the next 3D image. Alexa, show me the cinematic. Alexa, rotate the images. I don't want to break scrub and have to touch things. I want to be able to have Alexa do all of the work for me. So it's an interesting problem. And so the AI thing becomes a very, very important thing. I think AI is going to be very big in quality assurance. And this whole meeting, we're looking at things that go wrong. AI can allow you to predict where the issues are, where the dangers are, whether it's a broken window or it's someone washing the floor and the risk of someone slipping on a floor that's wet, but not, no one knows that the floor is wet. Can you use AI for risk prevention and risk stratification? I think the answer is probably yes, because we don't do a great job now. A computer, surely someone collecting all the data is really going to have it much easier to do. So I think that's very exciting, but the risk management perspective of things is very interesting, and I think that's going to evolve. The speed of evolving is going to be a little bit depending on how good AI becomes in the clinical world. The faster AI gets developed and adopted, the more these people will have to get things moving quickly. So I think it's very important in your practice to think about that how are you going to integrate AI? When are you going to integrate AI? What are the limitations? What are the advantages? What are the disadvantages? What exactly needs to happen to make it happen? And what's going to be the risk of using it or not using it? This world does not have, we're all risk adverse perhaps, but there is no, I don't think so. We'll just do what we did before. Those days are over. You're going to have to make decisions. So it'll be kind of interesting. Now let's see, we have a bunch of people online. So if anyone has a question, this is probably a really good time to ask the question because we only have a couple minutes left. I'm curious what people do think about this and how they do think they will use it in their own practice. What are you doing about it? Are you learning? I don't think you need to be a computer scientist, but where is the AI world going in terms of very simple applications? I mean, AI is being used now to schedule patients. You optimally use the patients. Is being used to schedule MRs so you don't have a lot of dead time and in between time. Can you optimize everything from that perspective? AI will be used to select or help you select the optimal protocol for the specific problem you want on the specific scanner you need. And on CT, very much the same things. How we do it, when we do it, the protocols, the report, the information to help the radiologist make the right decision. All of these things really, in a sense, use AI. Now, I guess you, Scott, says if AI delivers good outcomes, then adoption will happen. And can't argue with there. But I think what you need to do is you need to have a healthy skepticism. Of course, that's being reasonable that, we've all been through things where this is the cure-all for everything. But I think you need to be paying attention because I don't think this is a passing fancy. How successful it's going to be, we can argue that. I'm very positive about the process, but I think you need to be involved and integrated and thinking over the next couple of years where things are going and how you're going to build your practice around it and how it's going to affect your practice, how it's going to affect your patients, and how it's going to affect you. I think there's tremendous opportunity, but time will tell. I think also the fact is, as radiologists and as physicians, we have the opportunity to help drive the companies into coming up with applications that are really useful. I mean, often companies develop applications that a few people in the back room think are useful, and they really don't do any practicing like we do. So I think it's very important that we're actively involved with companies, with talking, whether it's at meetings or it's one-to-one. So we're very excited. I'm very excited, but hey, I'm an excitable person. I think you got to pay attention. I think you'll see in your hospital, and a few people spoke to me right after the meeting. They want to know how AIs can be used to help them, with risk management, to help them decrease bad events, whether it's on the imaging side, or the patient transport side, or on the nursing side, or in the OR. There is nothing we can't do better than we do now, because most things you see yourself, the error rates are high. Institute of Medicine talks about the errors, the lost opportunities for making great diagnosis. And so I think if we do things right, we have the ability to really deliver superior outcomes. And with that, I see my time is up. Anyone has any questions? Let me say hi to Liliana and Ava and the rest of you, everybody else. Okay, be good. Have a great week, and I'll see you next week. And hopefully, we'll be back here next Thursday, but I'm going to do my best when David Abitsky is here to see if I can interview him live on Facebook. And we probably will not give you a lot of notice because it probably will just happen. Catch you later.